Hi everyone, this is Danica, Austin, and Forrest recording our preoperative case study number 2. BD is a 48-year-old man who's scheduled to have a cholecystectomy under general anesthesia. He's a heavy smoker with a history of hypertension. He was admitted to the hospital with a myocardial infarction 2 years ago and now reports occasional episodes of chest pain and shortness of breath that's associated with mild exertion and relieved by sublingual nitroglycerin. His exercise tolerance is limited due to his painful knee. BD's past medical history includes a heavy smoke history of hypertension, obstructive sleep apnea, and chronic obstructive pulmonary disease, or COPD. BD indicates that his father and mother both died in their 50s from unknown causes, and his brother has a history of complications associated with general anesthesia. Current medications include CPAP at night, ipratropium, salmeterol, albuterol inhalers as needed for COPD. There are benign findings in the review of systems. Upon physical examination, his vital signs include a blood pressure of 160/105, pulse 98, and oxygen saturation of 91% on room air. Upon auscultation, his respiratory sounds express an audible expiratory wheeze with prolonged expiratory phase, but is otherwise clear to auscultation. BD had a pulmonary function test done 1 year previously that revealed a forced expiratory volume in 1 second of 60% predicted, with functional capacity about 4 to 5 metabolic equivalents. Before going to surgery, there are a few preoperative concerns that need to be addressed. This patient has multiple risk factors that increase the risk of postoperative pulmonary complications, including postoperative respiratory failure, atelectasis, pneumonia, exacerbation of the lung disease, acute lung injury, and pulmonary embolism. His hypertension is also a concern before surgery, as it can be associated with an increased risk of stroke and death. Due to his many risk factors, careful screening should be done before making an operative decision. Upon further investigation, the goal is to optimize conditions that decrease the perioperative morbidity and mortality. During the preoperative evaluation, other lab tests that should be obtained before surgery include a CBC, electrolytes, liver enzymes, and lipase. Since his pulmonary function tests are a year old, current pulmonary function tests would be beneficial, as well as a preoperative chest X-ray as baseline information in case he were to have any postoperative complications. One of the key points to think about when assessing risk factors and their effects on postoperative pulmonary complications is the surgical site. It is the most important predictor of risk for postoperative pulmonary complications, and aortic, thoracic, and upper abdominal surgeries are the highest risk, even in healthy patients. The incidence of pulmonary complications following abdominal surgery is around 22% in high-risk patients. Therefore, it is important to identify those patients who are at risk and develop a strategic plan to reduce their risk. In this case study, the best supporting evidence to decrease the risk of pulmonary complications in high-risk patients is to intervene with lung expansion therapy through the use of incentive spirometry. In addition to incentive spirometry, the use of deep breathing exercises and continuous positive airway pressure, or CPAP, has also been shown to reduce postoperative pulmonary risk following abdominal surgery. Early mobilization and ambulation postoperatively will increase lung inflation and decrease the risk for complications. With proper instruction and return demonstration, the patient should be encouraged to perform incentive spirometry independently with 10 breaths every 1 to 2 hours while awake. Smoking cessation should also be encouraged, but there is insufficient evidence to prove the benefit of preoperative smoking cessation, as it may actually increase the risk transiently after smoking cessation within 2 months of the surgery date, as this may increase secretions. There is also a possible benefit of laparoscopic compared with open abdominal surgery in relation to postoperative pulmonary complications due to decreased pain and increase in the ability to take in deep breaths. There is also some fair evidence that the selective use of nasogastric tube decompression after abdominal surgery also reduces the risk. clinical pearls to take away from this case study include the initiation of lung expansion modalities are the most effective way to reduce the risk of postoperative pulmonary complications in high-risk patients. The best supporting evidence to decrease the risk for pulmonary complications is to intervene with lung expansion therapy such as postoperative incentive spirometry. Essentially, pulmonary complications are very common. Therefore, it's imperative to identify high-risk patients and develop a strategic plan preoperatively to decrease their overall risk.